Hello, you're listening to Rebloom, a gentle space for women's health where science meets compassion and stigma has no home. I'm Tegan, and each week we slow down, peel back the noise, and make room for clarity about our bodies, our hormones, and most importantly, our lived experiences. This is a place to unlearn stigma, understand your body, feel supported as you navigate your own version of health. No shame, no overwhelm, just honest conversations, practical knowledge, and the space to grow. I'm so glad you're here, and let's rebloom together. So today we're going to talk about a topic that I think is really important for everyone to be aware of, especially if they've got older loved ones in their lives, like grandparents, parents, and something that people don't want to think about but should be mindful of. So we're going to talk about dementia today, but do you want to introduce yourself first?
Yeah, so hi all, my name's Dr. Brown. I'm a lecturer at the Montfort University and I've got a background working in the NHS and previously working on topics such as dementia. So I was a research fellow in the Institute of Mental Health where I worked at the University of Nottingham and then in the NHS at the same time, which was fun.
Yeah. Why did you want to go into dementia research?
So I do two main areas. I mainly do cancer biology and dementia now.
Yeah.
I used to be only cancer research until someone came to me with an idea of using one of the things we looked at in one of the cancer models. And they said, can we use this to look at dementia? So that was my first baptism of fire, as it was, straight into dementia, which was really fun. So that's where I wanted to go into that side because it was, I love biology anyway. Some of the stuff is so cool.
Yeah.
But then, that's the science side. But then also when I got married, I went and met my wife's family and I met her two grandparents who had dementia. So there's a little bit of both. Like the science is really cool to make things better, but also you see the real world impact is, as anyone who's had a family member with it, it's terrible and can be really alter your life in a big way. Yeah, few motivation.
Yeah, definitely. Thank you so much for doing this episode with me.
No problem.
Like I said, I think it is something that people need to be more aware of and more educated on because I believe it's quite a lot of people that get dementia, like I can't remember now what it is.
It varies depending on who you ask, but 1 in 10 is a conservative. 1 in 10 of us in our lifetime will get dementia in some way. And depending on our background, some of us are more at risk and some are less. 1 in 10 is still quite a high number.
Yeah. So as someone who has so much knowledge in this area, how would you define dementia?
So dementia's it's hard to give a specific thing to because it's almost like a group of diseases. Dementia is an umbrella term for, like, loads of people think about Alzheimer's disease. That's the biggest one, but there's loads of like vascular diseases, frontotemporal lobe dementia with Lewy bodies, all of that stuff. There's so many in there, but in the simplest form, it's a loss of function disease. So it causes your brain to stop functioning in a certain way, stop your neurons from stopping firing. So depending on which form of dementia you've got, depends on how that manifests, how it progresses and all the symptoms and stuff like that.
What is the difference between dementia and Parkinson's? Because I know that they're both loss of brain function.
Yeah. So Parkinson's is more looking at sort of a motor disease. So they both affect the brain in quite a similar way. And there is actually, you can have dementia with Parkinson's-isms.
Okay.
But you can get Parkinson's symptoms in dementia. But normally in dementia, you see those a lot later.
Yeah.
So with Parkinson's a lot earlier on, you see affecting the muscles. And if you've seen someone with Parkinson's, they do have a certain walk. They can't move as well as they could have. Whereas someone with dementia is still able to function quite well. There's actually one patient who, I can't talk specifics about patients for obvious reasons, but in theory, I met a patient once who was quite young.
Yeah.
He was in his 50s and he had a very active job either in the army or the police. So he was physically huge and super strong, still had a six-pack and everything, but he had an early form of dementia starting. But physically, he was in superb shape.
Yeah.
Whereas if he had sort of Parkinson's, he would have lost those abilities early, whereas he still had his physical, just not his mind.
Okay. I think that was a really good way of like showing the different sides of both of them. Because I know before you taught me this topic, I sort of put them in the same bracket and was like, oh, dementia and Parkinson's. But like you explained, it's definitely completely different.
Yeah, it's different and the same. Most people
Yes.
that do dementia will do Parkinson's and vice versa. So they cross over a lot.
Yeah, definitely. So you mentioned Alzheimer's disease. What is that?
Yeah, so most of the forms of dementia are caused by buildup of proteins in the brain.
Okay.
So think of your brain as a network of roads with cars driving up and down.
Yeah.
Imagine if you started putting roadworks all on those roads, it starts stopping the traffic from flowing. So in a way, pretty much all of the dementias are caused by roadblocks in your brain. Now, it depends what those roadblocks are. They can be proteins, they can be blood clots, they can be various things. In Alzheimer's disease, we normally see specific proteins, tau proteins that form and create these amyloid plaques, which are the roadblocks in your brain. So that's kind of how Alzheimer's starts, and that's where you see a lot of the memory loss and confusion because those roads are closed essentially, so they can't go down those roads to get the information you once had available in your brain.
Okay. I think that was a really good way of explaining it. So there are different stages, aren't there? Can you talk about them?
Yeah, so like I said, the three main areas of dementia to look at is, well, there are four, but there's vascular dementia. Vascular dementia, I'll only mention it briefly because it's more related to sort of strokes and things like that. When you see someone have a stroke, you see neuronal symptoms because it stops blood flow to the brain. Normally, that's something that we can reverse, so you can normally get better. It's one of the only forms of dementia that we normally can get someone back to full functioning after, whereas the other three that I'll talk about are more the loss of function that we haven't been able yet to restore. Yeah, you've already mentioned Alzheimer's disease, which is like probably 70% of all of the cases we see from dementia are Alzheimer's. A lot of people with Alzheimer's disease, because it's the biggest form, we normally is our go-to.
Yeah.
A lot of people, for example, with dementia with Lewy bodies, there may be in a county in the UK, there may have been like 10 cases in 1 year. As soon as there was education on dementia with Lewy bodies, that jumped from 10 to 55.
Okay.
Now, that wasn't because there was a sudden surge in cases, it's because those patients were being diagnosed as Alzheimer's disease.
Yeah.
Because it's easier to do that than if they didn't know the signs and symptoms for dementia with Lewy bodies, then they just go, that's Alzheimer's disease, it's loss of function disease. There you go. So, yeah, there's frontotemporal lobe dementia, which is again with a younger, so probably from around your 50s to 60s, whereas Alzheimer's is a bit older. And then you've got dementia with Lewy bodies, which has really specific symptom progression. So depending on which one you have, depends how it progresses.
Okay.
So like, think about your brain. Your brain, each part of your brain will work on a different thing. So one of the easiest to remember is frontotemporal lobe dementia. That affects the frontal and temporal lobes, hence the name first. So your frontal lobe is to do with your language and your personality mainly.
Yeah.
So as soon as, if you have a disease like frontotemporal lobe dementia, we'll normally see people have mood swings, and then that will progress to having personality changes and then memory loss, movement loss, and then the memory starts to get affected as well. So they all present differently, and depending on which person you speak to, we're all different, and it will all affect us differently as well. So there are typical progressions for each type, but not a typical progression overall, if that makes sense.
Yeah, that makes sense, yeah. So if someone came into a clinic and you thought they had symptoms of dementia, you would then look at the specific symptoms to try and figure out which specific type?
Yeah, it's a really interesting one. So one of the easiest things to do to see if someone is possibly going to have dementia is you assess their what we call cognitive function, how
Yeah.
well the brain's working. So there are loads of different tests out there. One of the ones that is commonly used is called a mini mental state exam. So I'm sure you're familiar from this. So I'm sure you're aware how simple and easy it is.
Yes, yeah.
So it's quite a good one. It doesn't diagnose if someone has dementia or not, but it can help assess how their brain functions or how it's functioning. So, for example, as it works through, it has different headings for the different things that we look for. So, if we go back to the different areas of the brain,
Yeah.
it will focus on areas to do with your frontal lobe, like language. So, someone will hold up, say, a pencil and say, "What is this?" to see if you can recall it. And that's testing the area of the frontal lobe to see, is this affected? And then some areas such as the date, the time, where you are, calculations, people, and color and shapes. So even though it's a simple test that we only really use to show cognitive function, quick and easy because you just sit down and it's a page of A4, you go through it with a patient, it can give you a good indication whether you need to do further tests to see if they have dementia or not. So that's our first line, is to do that.
Okay, awesome. Can nerves affect the results from the mini mental state exam?
Yeah, it's a combination of both things. So you can go two ways about it. You can either be really nervous
Yeah.
and think of it like an exam. You will know a certain amount about a topic, right? If you revise a lot, you'll do better
Yeah.
than ever. But if you have zero preparation, you're really worried and you're really anxious and you get in your own head about it, then you might do worse than probably what you should do.
Yeah.
In the same way with the mini mental state exam, it's the same sort of thing. You could go home and practice the mini mental state exam
You could.
once a day, and it'd be nice and easy when you go in because you've practiced each element. So when you come to the test, you could fake it.
Yeah.
And the other way of, if you're really nervous, you can do worse than you may expect. That's why a lot of this is down to clinical judgment as well.
Yeah.
So a lot of the times, unfortunately, it's one of the terrible things about dementia. We're really rubbish at diagnosing.
Yeah.
Like, as soon as we have someone in, that's the biggest hurdle. People will forget things. They'll attribute it to, I'm just getting older.
Yeah.
And it's okay, but it's also okay to get checked sometimes.
Yeah.
And it means that, obviously it's hard to estimate the amount that we miss, but in those primary care situations, it's estimated we miss about 20 to 50% of cases.
Wow.
Which is crazy.
Yeah.
And sometimes, this is the annoying thing as well, dementia with Lewy bodies has what we call fluctuating cognition.
Okay.
So I've sat down with someone before to do a mini mental state exam with one of the consultants there, and we've said fill it in. They've done 2 previously because we've taken blood from them at that point.
Yeah.
We did another one to check how they were. They actually passed with no cognition problems, whereas the previous 2 times they showed a severe cognitive impairment. Because they have fluctuating cognition, they actually showed us being okay. So in that moment, we didn't say, you haven't got dementia, on your way. We used some clinical judgment to go, okay, you've got fluctuating cognition, which is good.
Yeah.
It's probably where you've heard people say, oh, they've had a moment of clarity.
Yeah.
That's a bit along the lines of fluctuating cognition. Sometimes it'll be worse, sometimes it'll be better. We don't fully know why, but sometimes that'll happen.
Do you believe that, so obviously in a normal environment where you're not doing clinical trials, they would only have that one opportunity to have the exam, the mini mental state exam? Do you think that they should retest again with that same person? Obviously, I know there's already a lot of pressure on the NHS, but do you think it would show a better picture?
Yeah, in a way, I think the big thing is the mini mental state exam never stands on its own. You normally take it with patient history is one of the biggest things.
Yeah.
It's really vital for if you ever go into healthcare to realise that patient history is one of the biggest things that we can ask someone about, because someone might forget something that's normal, but actually asking them about those specific things, someone might brush something off, but actually it might be a symptom of something bigger, even when it's something minor. So one recommendation I have for people is whenever you go to the doctors, remember you are always the expert in your own health.
Yeah.
Because that doctor, what do we have, 10, 15 minutes with a
Something
GP?
like that, yeah.
You've had a lifetime living with yourself.
Yeah.
You know if something isn't normal, and it's good to go and check and ask these questions. And yeah, sometimes you can say, actually, having someone else there with you to say, oh, actually, can we do this again? Or we're not sure about this. Because there's always false positives and false negatives when in mental state exams. Because, for example, one element of the mini mental state exam is to have 100, take 7 off, take 7 off, take 7 off, take 7 off.
I would not be able to do that mentally.
Exactly. And you're not someone who's terrible at maths, but if let's say you didn't get a GCSE in maths, how horrific would that be? So all of a sudden it might not show cognitive impairment, it still shows their cognition, but if you're bad at maths, you're bad at maths. That doesn't show you've got dementia, that's just
who you are. I think especially with like the older generation, when they was working from a younger age and, school wasn't as important or as rooted in childhood as it is now. I think that might also affect the reflection of the exam as well. Especially like we say, like with the literacy, and being from where I'm from, we always talk in like half a sentence and we call stuff words that aren't it.
Yeah.
The good old question of like, what is a cob? Is it a bath? Is it a roll?
I'm still in arguments with my wife about if it's scone or scone.
It's scone. It's got to be a scone.
Yeah. So, we can keep...
Not over now. Yeah, so I think I like how you said that it's not the be-all and end-all for a diagnosis. But yeah, no, thanks for explaining that. And I think it might be nice for people who have someone who might be going through that exam to know that it's not a very difficult exam. It's not going to be taxing on them.
No, it's very simple. And I mean, it normally depends on who you have as your doctoral consultant in that moment. I've seen people do them who've just tried to rush through them and it's not been as well. But then there are some amazing people in the NHS who take some good time. And one of the consultants, when I went to take bloods, we only gave sort of 30 minutes for an appointment to go to someone's house, assess, do all my tests and then take bloods and take them to the hospital. Normally 30 minutes to an hour. We were there for 3 hours. The patience of this consult was amazing.
Yeah.
So some of them can be so good and so like gentle at going through things. But yeah, it's not the be all and end all. I mean, all of these tests are just a small part of the larger picture, really, that they're just trying to work out.
Yeah. And it's in their best interests as well.
Yeah. Yeah, because I mean, we misdiagnose or underdiagnose a lot with quite a few things. So it's... people do want to do well, and we do want to, treat people for what they need to, because the earlier we can get, things like this found, the better we can prevent them. I mean, that's what a lot of the treatment is on.
Yeah.
As we said, we don't have any treatment to cure it, which is a shame. Hopefully one day. And we don't even have that much to test for it, sort of biologically. But what we do have, there are different medications. There are 2 main forms. One is to prevent the build-up of more proteins, and the second one is to get your brain to fire more, so more neurons to fire. So that only works if there's still some cognition there. So the earlier we can find a patient with dementia, the better they can have a quality of life.
Yeah, and like slow down the progression.
Yeah, exactly.
Yeah. Exactly. Awesome. So what do you think? Do you think that social media and that has an influence on speeding up looking for like treatments for dementia and putting it out there?
I think social media can have like a double-edged sword of it, because I think it depends how you use it. Like any tool, one of my favorite quotes recently was from another podcast with a guy called John Lennox.
Yeah.
Yeah. Did you see it?
I think I have, yeah.
He had a great line where these things are a tool. He's talking about AI, but he says, a knife is a knife. A sharp knife can either be used for precision surgery or to harm someone.
Yeah.
And in the same way, social media can be a huge blessing. You can get so much information so quickly from it, but it can also be a monumental waste of time.
Yeah.
But it's a tool, so it depends how you want to use that or not use it.
Yeah, definitely. It's like going on another tangent. There was a study that came out saying that coffee reduced the risk of dementia. Did you see that study?
No, I didn't.
Okay. So I seen it on a TikTok, and this guy opened 5 cans of Monsters and started downing them because he was like, I'm not getting dementia. And I was like, no, but you're going to get heart disease. But you can't, that's not how this works. And then I did some research into it. And I was like, it's only like up to like 30 milligrams of caffeine a day or something. Yeah. So it's like, it like cut off, and it was like, after that, it didn't improve it very much, like decreasing the risk.
That's the big difference, I think, how you use it well as a tool. What you said is, I saw it, and then I checked it. So the difference between you and that guy is he saw it and went, great, as much caffeine as possible. He's taken the headline and ran with it. And then obviously that's led to some really wrong conclusions, which will probably damage him in the long run and give him a heart attack. And probably not sleep for 3 days. But whereas you've gone away and you've looked at going like, oh, what's the actual evidence? Because so many times we're very much a sensationalist culture where we want the big interesting stuff. And we're all guilty of it.
100%.
It's whatever catches our attention, but it's having that mindset of going, let me just check if this is right. Because there's some amazing stuff out there. Like, I remember when I first was starting, I'd finished my undergrad and I was reading a paper, and it was about how your mouth health, how brushing your teeth affects your risk of dementia, because the bacteria in your mouth can have an effect on the protein built in your brain. There was one small paper which did show a correlation, not a big cause. So that, I think I'll say that before everyone pauses your podcast, brushes their teeth and comes back. But it does show you that there are so many small elements of health that come together to form a risk. You know, it's not all based on caffeine. It's not all based on brushing your teeth. But they all have little effects on, and that will overall have a big effect on whether you're protected or you're more at risk.
Definitely. I just found it crazy because it had like 300,000 likes. And I was like, I hope 300,000 people don't start drinking like 5 cans of Monster a day, thinking like, I'm never going to get Alzheimer's. I'm going to be fine. Yeah, honestly.
Yeah, it's pretty crazy.
I think people do forget, like, you don't think about like stretching your mind or, you know, keeping your mind like active in a way. You just, especially now with, again, social media and like, you know, the brain rot, it's definitely interesting and something that more people should do.
Yeah, but this is, I mean, there's two bits I always think of when I come to this. It probably shows my age a little bit. But did you ever have the little Nintendo DSs?
Of course.
Great. In those, they used to have, it was like a brain training academy. Yeah. So there were different studies using that game that would look at how you could activate the brain. So they used it in people who are older, even gaming in general, to get people problem solving. Because a lot of games that we have are problem solving games. Normally we look at games and go, oh, they're terrible. But if they are problem solving based games, they can really help our cognition. And I mean, on Chris Hemsworth again, because they said, okay, what should we do to keep our brains active? They said, great, so start by giving me your phone. And that is a scary moment, isn't it? You're like, there you go. But it stops. Their point was more on navigation. So if you were to walk around somewhere, I did it today. I went for a walk I walked out a kilometre or two, and then I just looked for a nice route back.
Yeah.
20 years ago, 10 years ago, I wouldn't have done that. I
Yeah.
would have just turned away and tried to find my own way.
Yeah.
And it's one of the most complex tasks you can do. It's just finding your way in a situation, of knowing where you are, going down here, going down there. And that's what they challenged them to do. I mean, they did an extreme way where they went trekking through, I think, like, I don't know where it was, a forest for like 2 days, and
It's like,
said,
right, there you go.
find your way. And so, I mean, we don't all have to do that.
No.
But it's an interesting one to think about. Like you say, how are you challenging your brain, or are
Yeah.
you just doing things that are comfortable and easy? Because that can protect as much as anything, and it
Yeah.
can probably help you in the long run.
Yeah.
So I ended up speaking to I can't remember where they work now, but a neurologist. I think they're down in the Wellcome Trust in Oxford.
Okay.
And I was chatting to them about it, and they showed me a study where they did brain scans against those who did use AI and those who didn't.
Yeah.
And the activation of the brain when someone used AI was like 10% of what those who were thinking through their problems actually were.
That's crazy.
I mean, your brain is absolutely phenomenal.
Yeah, let's go for it. So what is Lewy bodies?
So Lewy body dementia was kind of like my area in the Institute of Mental Health, because we were essentially, if you think dementia's underdiagnosed, dementia with Lewy bodies is the underdiagnosed area of the underdiagnosed area.
Okay.
It's super, like, we don't know what's going on with it, but it's also really interesting as well. So we, like I say, we miss so many cases of it because people just haven't been aware of it as long as they have sort of Alzheimer's disease. So Lewy bodies are how I spoke about Alzheimer's, and they have these little tau and amyloid plaques. So instead of having the same plaques, they have what we call Lewy bodies. So they're the little balls of protein that grow in the brain that again act as those roadblocks between those different areas and causes them to misfire in some ways as well. So that's what Lewy bodies are. It's dementia caused by those Lewy bodies.
Okay.
It can be it's really interesting, but really, really heartbreaking at the same time. So the two biggest things that are specific to Lewy body dementia is visual hallucinations and acting out your dreams.
Okay.
And probably to add a third onto there's also aggression, which in later stages you can get. There's been many times where I've gone to work in the morning and I look through the database of the patients, and I see that last night one of the patients had got up and was shadow boxing all night.
Oh.
So they were in the ward,
Yeah.
shadow boxing, just ducking and diving and punching. And I mean, particularly Lewy bodies mainly affects men as well.
Yeah.
Women are more affected by dementia. So it's an interesting one that we don't know why. But yeah, then the other one is hallucinations, which is phenomenal. So it's not just, when we think of hallucinations, I normally think of, like shape, or did I see something down the corridor? Like almost like,
Yeah.
did I see a ghost?
Yes.
Yeah.
I do that.
But instead, when you talk to these, they'll tell you details as if that person was stood right in front of them. So one told me that he had for example, someone walked in from the army and he'd given him a secret mission to do while he was still on the ward, which was quite interesting talking to him about. He could tell me colour of his shoes, all of his previous, where he'd been, what rank he was, what hair colour, what eye colour, if he had a top button undone or done up. For him, it was as real as I was sat.
Yeah.
So it's really, really interesting I mean, it's heartbreaking for them because it's hard then to distinguish reality between non-reality. It can be quite distressing. I mean, I don't know, it's not the same thing, but have you ever seen the film Beautiful Mind?
I recognise the name.
But it's more a psychological case than dementia, but it's a good one for showing visual hallucinations, because he was the same sort of guy a guy played by Russell Crowe called John Nash, who you still learn about his stuff. If you do maths at university, you still learn about John Nash and his theories because he was that good.
Yeah.
But he had psychological problems where he would have visual hallucinations. So he was convinced that the CIA had recruited him to crack codes between, I think it was Russia that was sending him to sleeper agents, but he fully believed it, and he would spend hours working on it, and it was never real. And that became really disconcerting to him. Like he kept working at university, kept teaching, but it really disturbed him because for his whole life he had visual hallucinations, and he would ask people, is that real? Is that person real or not real?
Yeah.
Like in this room now, if someone walked in, if you were John Nash, you would go, is that person real? That can be that's really disconcerting.
Yeah. That's heartbreaking as well because, imagine trying to tell them, like, no, that's just a hallucination that you're having. That must be so scary for them to be like, it's there, it's right in front of me. What do you mean?
Now, have you ever woken up from a dream and you've been convinced that dream is real?
Yes.
That is such a jarring moment where you're
Yeah.
shocked back to reality, isn't it?
Yeah.
So in the same way, I always think of dementia patients like that. Do you really, in that situation, do you need someone going, that's not true, they're not real, like that's going to just make you feel bad, it's going to shame you, make you feel worse. Like if you put yourself in their shoes, how would you want to be treated?
Yeah. Definitely.
Like in a similar way, there was one writer who wrote what's called, the Narnia books.
Yeah.
C.S. He not just a kids writer, but an amazing academic. He ended up reviewing 50 different religions to see if any of them were right, any of them were wrong. And he's in part, it's quite an interesting read. And part of it, he says the one thing that is the same across these is the golden rule, which is treat others how you would like to be treated. And you're like, if that's in all 50 religions, if this is a universal thing that everyone is agreeing around the world we should do, for some reason with dementia patients, we instantly forget it.
Yeah.
And we just go, no, let's correct them. And you're like, it's not what I would want in that situation. So why would I do it to them?
Yeah. I think especially with, like you said, dementia with Lewy bodies, they get mood swings and are more likely to get angry and frustrated. So if they're having hallucinations, someone stood next to them like, that's not there, stop it. Or like, you're being like, not crazy, because I know they're not crazy, that's a bad word to say. But like, just being like, it's not there, when it's just as vivid for them as, like you said, the person sat next to them. It must get them so much more frustrated than they're already feeling.
Yeah, and that's it. In the same way, I know in the lectures that I gave to you, I included this video. And I stumbled across this video, and it must have been from the 90s. It was quite old, but it was about dementia and how it interviewed a lot of family and caregivers about how would you approach someone with dementia.
Yeah.
And there's one woman that goes in there like, I just lie. I just tell them little lies. They're only white little lies, so it's fine. And I'm like, in that same way, would you want someone lying to you?
Yeah.
So, and then another one who's my favourite woman in it, who massive, like, his 90s hair, will just go, right, if my mother tells me that there is a pink and green spotted cow in the front garden, I'll go, right, do you want me to milk it or move it?
Yeah.
And I think that's such a good way to go about it. It's either you enter their world or you distract them.
Yeah.
Essentially, a lot of people have family members, or our family friend they have a little toddler.
Yeah.
Who's 3 years old now, who is great, little Ezra, who runs around. So much fun. He'll run up to you like any 3-year-old and he'll go, do you want a drink of tea? With a little plastic cup with nothing in it. Now, in that moment, are you going to go, this has nothing in it? That is unacceptable. Go boil the kettle and make me an actual cup of tea. Like that. Yeah. We're more than happy to enter their reality when they're 3, but not when they're, when they have dementia. And in a way, how is that any less real? You have a great time with the toddler when you do that.
You do, yeah.
So you can have a great time with family and friends when you do enter their world or their reality.
Yeah.
But I realise sometimes that can be difficult.
Yeah.
Yeah, there was, I think, one part of a movie that I was watching. I think it was called like God's Not Dead. And there was this girl who goes to her mother, who is in a home for dementia. She's over the moon that she's got chicken that day for dinner.
Yeah.
And she goes to her like, oh, when was the last day she had chicken?
Mm.
She was like, oh, she had that yesterday for lunch and dinner and the previous day. And she's like, should we be doing that? Should we stop it? Like, should we tell her? And she's like, is anything else going to make her as happy as she is eating that chicken right now? And you're just like, yeah, what's the harm in that moment?
She's eating as well.
But then it's difficult because a lot of people enter this world not by choice.
Yeah.
The whole area of dementia is something that just happens to you. It's really difficult to go from someone caring for you to all of a sudden you caring for them.
Yeah.
And that can be really, it's such a difficult transition to make. And, we don't normally prepare for it, so we don't think about this. We just cope by lying or distracting or doing something we shouldn't, which can be sometimes damaging.
Yeah, definitely. But how else can family members and people working in this sector actually support people with dementia?
I think one of the biggest things throughout all healthcare that you go into sort of counselling, healthcare, whether anything, you've got to look after yourself first.
Yeah.
You've got to put things in place to make sure you are okay, because you can't look after anyone else if you can't look after yourself. So primarily, give yourself a support system and network, people, friends, family, who will be there to support you, because you need to look after yourself before anything else. And I think we can almost forget that when we really have to look after someone, you kind of forget yourself. Parents do it when they have kids for the first time.
Yeah.
You see, they buy everything for the kids and then their shoes are breaking apart because they don't want to buy new shoes for themselves, they'll buy it for their kids instead.
Yeah.
It's a great thing to do and it's a great heart to have.
Yeah.
But you do have to look after yourself as well as looking after them. So that's always the biggest thing. But then practically what to do is building in routines, reminders, like you can put labels around the house, labeling the medication, setting things out, having things in a normal and expected routine can be really useful.
Yeah.
Because I think we all find that, don't we?
Yeah.
A routine is nice. We know what's happening. We know when it's happening. So
yeah, awesome. What about like day to day? What can people do for people with dementia? Because I know, obviously, depending on like family members, for example, they might not be able to have the time to like sit with them all day. But what can they do when they have got the time to be with them? What activities can they do?
I think there's a few things there because, like you say, you're not going to be there all the time. But there's some really cool things out there about like interventions that you can do. And I know intervention sounds like a big word, but it's more a sciencey word for just stuff you do with them. So one of the biggest and long-standing ones is music.
Mm-hmm.
So particularly, there have been some people that, let's say they've played music their whole life. You put them back in front of a piano and they'll still be able to play even with dementia because it's just more muscle memory and they can just play and it can start firing those neurons, which is exactly what the therapy tries to do. The drugs that we give try to fire neurons.
Yeah.
Anything we can do to do that naturally can be really good. Getting them to play music if they played it before. If they loved the music as they were growing up, play something that they knew growing up, like play them the biggest hits from, the years when they were 18 to 25, because normally they'll tap along, they'll come alive a bit more, which is really cool because sometimes you can go from someone who's a bit more catatonic, who isn't that responsive, and that you can see movements or head bops, and it can be a nice moment of connection. And then, it always depends where they're at in their journey through dementia, because there are other things like you can sit and read with them, talk to them if they're a real person. You don't just have to talk about them or just yourself, but bring them into problems, get them to think, share your life with them, because they'll want some of that because they'll miss some of that. And even there's a cool study happening at the minute, and I've seen a few papers out about it, but then I saw it on the Chris Hemsworth thing as well, that there was the one on Limitless there is a study, I think, off in Norway where they call it dance therapy.
Okay.
And what they do is they literally just dance. So they come up with a routine, and it's a combination of they get out and have social interactions, they have music that they enjoy, and it's movement. So all of those fires all the areas that we need to. So having all of those areas can be it seems something really simple, but that can really help them get long quality of life and really enjoy it. Plus, you can create a real connection and moment with them. If they still are able to go and do that, which I do admit not everyone with dementia will be able to.
Yeah.
But it's just, everyone will have their own interests.
Yeah.
Ask them what they want to do.
Yeah.
And then try and facilitate that as much as you can within reason.
Yeah. That's really sweet though. And I think as well, when you say music therapy, like if they're singing along as well, that might help with their speech.
Yeah.
Like trying to form the words as they're there, I guess.
Yeah, I mean, there's so many things. There was this person who started playing, I can't remember if it was something like Call of Duty or something like that, and that helped his cognition.
Wow.
Because he enjoyed it. And thing is, I recommend this with people with anything, whether it's research, whether it's exercise, whether it's food, find what you really love doing, and then it's not a real problem to do it, is it? If you love, let's say you love cycling, it's not going to be a problem to go and cycle. But if you hate cycling and I said, oh, you should do this for fitness, then you're going to begrudgingly do it for, half an hour a week? If you love it, you're going to get on your bike every chance you get. So finding something you love and they love, that common ground, can be a really beautiful moment as well.
Yeah, definitely. I know I think that's some really good things for people to be able to do with family members suffering with dementia, or just, if they work in that sector. So you're talking about the misdiagnosis age being around 20 to 50%. Why do you think this is?
I think it's one of the biggest things is we don't have a real biological way to show it. So if you had an infection, we could take that away, do blood cultures and tell you what the infection is. If you had a problem with your thyroid, we could test the different areas of your thyroid to see how they were working. With dementia, we don't have an easy blood test to do it. The only test, so like I say, my area was with dementia with Lewy bodies, and there is a specific test you can do, but it's available in very few, I think 2 hospitals in the UK. It's a very specialist scan which looks at dopamine receptors in the basal ganglia to see is it decreased. And then you get the clinician to interpret that. So you can imagine with this being so common and 2 places and the difficulty that it would be to get someone to travel, all the way up to Newcastle to get it done, there are huge problems in that. It's why I started the research project I did. So there was a consultant who got the funding for it and he brought me into it, but it was trying to develop a blood-based biomarker for dementia, because imagine instead of doing a mini mental state exam, doing this, that, the other, you normally get blood tests, particularly when you get older anyway, you might do normal health checkups. If you could take a little bit of blood, send it away, do this test and go, you are early stages, then that would help. But we don't have that. We just have someone asking you questions, and you can diagnose dementia with Lewy bodies without actually doing the test. It's based on the clinical presentation of the patient, which is good because we need it, because we've got no other way. That's why we need more ways of doing it. Because I think we forget how we've come so far in science, but we've still got so much further to go. Which is exciting, but also can be terrible when we realise the effect that it has of us not actually having this stuff yet to diagnose people.
Yeah, definitely. And there's that whole debate as well, now that we're living longer, we're more likely to see people with dementia. And obviously that's going to increase cases and also mean that we do misdiagnose people more. It's going to happen whilst we don't have the technology and the ability to.
Yeah, I mean, it's a huge thing with thankfully, healthcare is getting better, so we are living to be older and older. But I think the other thing is having a quality of life till we're older and older as well. I think, I can't remember which, there was a comedian that said, like, if I stop eating or stop doing things that I shouldn't be doing, like eating red meat and start exercising and all of this, like that'll add 7 years onto my life. But that'll be 7 years to the end of my life when I'm older. I'm not able to go around and do things. So he was like, I might as well live my life to the fullest extent right now.
100.
I don't fully agree with him, but I do get the idea of what's the point in us living even longer if
Yeah.
we're just going to be catatonic in a bed or something. Yeah.
But then it also brings up the debate of like, if you do this stuff, it means that you can be more physically able for longer as well, like exercise.
So you remember when I talked about the APOE gene related to Chris Hemsworth and the increased risk? That gene is linked to carrying cholesterol around the body.
Oh, okay.
So when you think about that, even if I didn't say it, you can logically think, okay, if this gene is one of the biggest risks for dementia and that's linked to cholesterol, then cholesterol is linked. So in the same way, anything that will reduce your cholesterol can help. Whether that's eating fish, that can be really good for reducing your cholesterol, or exercise, both anaerobic or aerobic, can be really good, whether you're sprinting, going for long runs, whether you're just doing a little bit of exercise. I think it all comes into like that for view of all of it. It's not one thing.
Yeah.
I mean, there might be research out on there, but I'm not sure at the minute. I think any exercise is good exercise.
Yeah.
But I'm sure one might be a tiny bit better than the other.
Yeah.
Find something you enjoy and that'll be the best.
True. Anything's better than nothing.
Yeah.
I get you. Say I believed that my grandma had dementia, for example. How would I know that? How would I be more inclined to know, okay, this is dementia and not just...
Yeah, so I ended up saying this to my own dad the other day. So my dad will constantly worry, like, forgets this, forgets that. He goes, oh, I'm really worried that maybe I'm getting dementia or something. And I'm like, I'm probably not the right. I don't want to be diagnosing my own dad. Not allowed. But so when he says, forgot where I put my keys, or like he would leave somewhere and go, oh, where did we park? What floor did we park on?
Yeah.
That's when I go, that's normal.
Yeah.
I mean, we've all done that. I've lost my keys multiple times or lost my phone a few times. It always happened. But there's a difference. I said to my dad, there's a difference between losing where you park the car and forgetting that you had a car in the first place.
Yeah.
That's the big difference. If you completely lose any knowledge of an area, that's very different. And I think it's very noticeable.
Yeah.
And you, like I say, you are the expert of your own health.
Yeah.
You know what it is normal to forget and remember. If you start saying things you're forgetting a whole lot more, then maybe raise it as an issue. But if it's just little things, then I wouldn't worry too much.
Do not panic.
Yeah, I wouldn't panic at all. And I think as well, you've got to look out for the people in your life. And this is a challenge for everyone as well. If you start seeing someone, that walks, changes, they start forgetting things a lot more, they're changing their personality, tell them. Because a lot of time we don't realise these things are happening. It's like, there have been times where, I've had like a pizza for dinner and I get a little bit of tomato sauce on my face.
Yeah.
I have no clue until someone goes, Tom, you've got a bit of tomato ketchup there. And you go, oh, sorry, yeah. And in that same way, it's where it's really good for us to learn to challenge each other to say, you're not normally like this. Because it will both come into either catching dementia earlier or any mental health conditions. Because there's so many things that can affect us. You want to be a good friend and start challenging your friends in a kind way.
Yeah.
Again, in the same way, we don't need any aggressive ways of talking to friends. Just nice, gentle challenges and questioning can be really healthy.
Yeah.
I think.
And I think as well, you can correct me if I'm wrong, but like if someone is talking about a memory, like talking about it and not talking as if they're in the memory in a way, I think that might be like a good sign.
Yeah.
Or like maybe more of an indicator if they believe that that memory is happening right now.
Yeah.
But yeah, I think that's just something I've picked up from like your slides and this discussion today.
Yeah, that's it. Everyone is different. Everyone will present differently and progress differently. And that can be really frustrating because normally we're built that we just want an answer.
Yeah.
So it can be frustrating, but it can be really empowering as well, because if you know that person, you can help them in the best way possible. In a lot of ways, you don't need doctors always to help. It's the little things we can do can make a big difference in their life.
Yeah, definitely. We did new research, didn't we? It's definitely an area that needs looking at.
Yeah, everyone at the minute everyone is looking at diagnosis. Not many people are doing treatment.
Yeah.
There are only a few, so everyone's looking at either genes or blood tests or spinal fluid tests.
Yeah.
Yeah, it hopefully will present something.
Yeah.
But as you can imagine, it can be quite difficult sometimes.
Yeah.
I mean, like that guy who was quite strong. I could never get blood from him.
No.
I didn't dare. And like, if
No.
I can't dare to get blood from him, how are you going to get spinal fluid from him?
Great point.
Like, and that's some of the tests that there are tests that use spinal fluid, but they're still not there yet. So hopefully we can have a nice, easy one. I mean, it's the same for cancer as well. They're always trying to make blood tests for cancer, so we can just take blood from someone, put it through 20 different tests, and then you can know if someone's getting cancer, dementia,
Yeah.
or 10 other things.
And it's like not as easy as something like thyroid because that releases hormones, so they're going to be in the blood.
Yeah, we do a
Whereas, like,
specific test.
Yeah, you can't take neurons out of the blood.
This is the problem with diagnosing dementia. Do you know the best way to diagnose dementia?
Yeah.
To take the skull off and look at the brain. So like we do post-mortem analysis where you can literally take someone's skull off and look at the brain and go, look, this is the specific type. These are the proteins. This is this. This is that.
Yeah.
But we can only do that after the fact.
Yeah.
So yeah, we still need to get a whole lot better. But
Yeah.
because it's all limited to the brain, because I don't know if you came across the blood-brain barrier.
Yes.
So that's incredibly great for when we're thinking about our health and things not getting to our brain. But it can be incredibly annoying when we're trying to look at what's going on in the brain.
Yeah.
Which is why it can be difficult to have a blood test, because it needs to go from the brain through a barrier into the spine and into the spinal fluid, down the body, then into the blood.
Yeah.
So you can imagine it's so dilute when you do that. You never know. Maybe soon
Maybe.
we'll get something.
Yeah, definitely.
Not quite.
Not yet, but in the future.
Yeah.
And I think with the NHS being more on like the preventative side of health rather than the treatment side now, it's obviously going to make it treatments aren't going to be funded as much and so on and so forth.
If you can do more preventative stuff like that, it would save us so much. But at the minute, we spend 2% of our budget on preventative medicine.
Yeah.
And 98 on, oh, it's gone wrong, we need to fix it.
Yeah.
Hopefully we'll get better.
Yeah, definitely.
So that was what we call a feasibility study on if we can develop a blood-based test for dementia generally to see technically is it possible. That had a lot of funding for it, closer to $500,000
Wow.
and that was not a massive study.
Yeah.
So we need a lot of funding put into that before we can have a test that then is cheap and easy to do. Because in theory, that test only cost a few pounds every time we did it.
Nice.
It's getting that viable and reliable, because there's so many tests that we used to do that just weren't reliable. The standard's a lot higher, which is a great thing.
Definitely.
But it just means we need a lot more research to be sure, because you can think what it's like if you're misdiagnosed with things.
Yeah.
Or underdiagnosed. Both are terrible, but yeah.
What other findings for your study, if I'm allowed to ask? Promising?
Mix. Very difficult.
Yeah.
So I got brought on as the lab head of it.
Okay.
So the person I worked with was a consultant in the NHS who is a phenomenal consultant. He's incredible at it. But realizing the limitations of how much. So we were trying to get we were looking at RNA as a biomarker.
Okay.
So we would take blood and extract RNA out, and then see if we could use this panel
Yeah.
to. I mean, you can have a look at the paper. You can see the panel to see if the RNA is there or not. The amount of RNA we had was not in. So as you work down, you work from sort of like milligrams, which isn't much, to like nanograms, to like pictograms. We had pictograms of RNA because they were so small. So we were looking at these little balls called extracellular vesicles. We cracked them open, took the RNA out, but there was so little in there. You would have to take so much blood to get enough RNA. And so it's possible, but I think we just need a bit more refining before we can. We have got a study going on now, which has closed for recruitment, which will hopefully tell us if we could do it. We've done it with 10. We've recruited, I think, 120. So hopefully that will tell us with a bit more significance whether that's happened or not.
Yeah.
But again, we don't know. It's the joy and pain of science. It's really exciting, but we don't know if it's worked or not worked.
Yeah.
So we'll wait and see.
That is awesome though, if it does.
Hopefully.
Before we wrap up, if you could say one thing to the listener who might have a family member with dementia or worried about someone with dementia, what would you say to them?
I think I would say, first thing is always don't panic.
Yeah.
I would always say talk to someone about it, because sometimes we can get very much in our own head about a lot of things.
Yeah.
But actually sharing it with someone else, as humans, we're built not to do things on our own. We're built to do it with other people. So it's good to talk to other people to see if it is or isn't an idea. And at the end of the day, when we talk about friends or family who are affected by dementia, they're the same people who you knew for years and years and years.
Yeah.
And it's not losing that, because it can be difficult. As time goes on, people will change, or their needs will change. They're still the same person with the same loves and hates and desires and all of that. So it's remembering that person is still a person at the end of the day.
Yeah.
It's not all on you to make their life perfect.
Yeah. I really like that. That's really sweet. Thank you so much for coming on today.
No problem.
I think dementia is something that I did want to talk about, and it can really take over people's lives, not just the person with the condition. So,
it's like I say, a lot of biology is cool and interesting.
Yeah.
But it's so devastating.
Yeah.
And I don't think I've picked two great specialisms of cancer and dementia. They are, because they're both equally interesting, but so devastating when you see the effects happen. It can be, it can really change your life.
Yeah, definitely. Yeah. Again, thank you so much for your time.
Thank you for listening to Rebloom, where we turn women's health into clarity, confidence, and compassion. If today's conversation sparked a question, or maybe a new perspective, then I'd love to hear from you. Remember, your health is worth understanding, and your voice is worth using. See you in the next episode.